Welcome to the series of biochemistry lectures. Now, today's topic would be on the diabetes mellitus. Now, diabetes mellitus can be classified into two types. Type 1 diabetes mellitus, which is seen in the younger population, whereas the type 2 diabetes mellitus, which is seen in the elderly population. Now, the type 1 diabetes is because of the lack of insulin secretion, and type 2 diabetes mellitus is because of the lack of insulin receptors, or due to resistance to the action of insulin. Now, these are the two major types. Then there is also gestational diabetes, which is seen in the pregnant mothers, and this gestational diabetes later on may develop into actual diabetes mellitus, or it may not occur after the delivery. Now, type 1 diabetes mellitus, the individuals are not obese, and whereas the type 2 diabetes mellitus, the individuals are mostly obese in nature. Now, in type 1 diabetes mellitus, it is due to an autoimmune response to the beta cells of the islets of Langerhans, in which case there is a gradual degradation or the damage to the beta cells, thereby decreasing the insulin secretion. Now, diabetes mellitus type 1, they are more susceptible to have diabetic ketoacidosis, whereas type 2 diabetes mellitus, the diabetic ketoacidosis is not that common. Now, looking at the various effects of diabetes mellitus, there are both acute complications and chronic complications. Now, the acute complication include the diabetic ketoacidosis, and this is mainly because there is a decreased level of insulin or an absence of insulin, so that the opposing hormone, that is the glucagon, has got more predominance, and the glucagon can activate a hormone sensitive lipase in the adipose tissue, so that there is a continued lipolysis taking place, and the adipose tissue triglycerides are lipolyzed into free fatty acids and glycerol. So there is an influx of free fatty acids in diabetes mellitus, and now these free fatty acids that are entering the blood will be taken up by various tissues and will be used for energy purpose. Now, the free fatty acids have to be used for energy, because the glucose cannot be utilized as the insulin is absent. Now, the insulin, as we know, activates glycolysis, that is by activating three enzymes: glucokinase, phosphofructokinase and pyruvate kinase. So these three are the unidirectional enzymes, irreversible enzymes, which actually increase the rate of glycolysis. Now, as insulin is not present, these three enzymes cannot be activated, and hence there is more lipolysis, and free fatty acids are used for the energy purpose. Not only that, the hormones, the enzymes responsible for the gluconeogenesis, that is the pyruvate carboxylase, phosphoenol pyruvate carboxykinase, fructose 1,6-bisphosphatase, and glucose 6-phosphatase are all increased by the glucagon hormone. Now, as we know, pyruvate carboxylase converts pyruvate to oxaloacetate in presence of carbon dioxide and one ATP molecule. Now the oxaloacetate is converted to phosphoenol pyruvate with the help of PEP carboxykinase by removal of carbon dioxide and in presence of GTP. The first enzyme, that is the pyruvate carboxylase, also requires biotin for the addition of carbon dioxide. Now this PEP phosphoenol pyruvate intermediate will go up to the stage of fructose 1,6 bisphosphate, which will be converted to fructose 6-phosphate, and for this you need the enzyme fructose 1,6 bisphosphatase. Now the conversion of fructose 6-phosphate to fructose 1,6 bisphosphate is done by another enzyme, that is phosphofructokinase. Now the fructose 1,6 bisphosphate, as I told you, is converted to fructose 6-phosphate, which is further converted to glucose 6-phosphate, and glucose 6-phosphate is ultimately converted to glucose with the help of glucose 6-phosphatase enzyme. But the conversion of glucose to glucose 6-phosphate is done by glucokinase or hexokinase. So, in the absence of insulin and the predominance of glucagon, there is increased synthesis of glucose from non-carbohydrate sources like lactate, pyruvate, glucogenic amino acids, and also glycerol. Glycerol can be converted to glycerol phosphate, glyceraldehyde 3-phosphate, which can be isomerized to dihydroxyacetone phosphate, and dihydroxyacetone phosphate and glyceraldehyde 3-phosphate can combine in the presence of aldolase enzyme and can be converted to fructose 1,6 bisphosphate. By a backflow, it can give rise to glucose. Now, so gluconeogenesis is more, although there is a raised level of glucose in the body. Not only that, the lipid metabolism, as I have been telling, that there is a lot of free fatty acids produced. These free fatty acids are taken up by various tissues, and then it is oxidized by beta oxidation. Now, beta oxidation produces acetyl coenzyme A. Now, this acetyl coenzyme A normally goes to the TCA cycle by combining with oxaloacetic acid, but now there is a decrease in oxaloacetic acid also, and this is rather diverted for the formation of glucose in the case of diabetic patients. Because then there is a lack of oxaloacetic acid, and acetyl-CoA will not be entering the TCA cycle. Rather, acetyl-CoA will be converted to the ketone bodies. Now, in ketogenesis, two acetyl-CoA molecules join to form acetoacetic acid in presence of the enzyme acetoacetyl-CoA synthase. Now, this acetoacetyl-CoA combines with one more molecule of acetyl-CoA, and it forms the HMG-CoA, that is hydroxymethyl-glutaryl-CoA, in presence of HMG-CoA synthase. Now, this HMG-CoA that is formed is split by a lyase enzyme, that is the HMG-CoA lyase, and it forms acetoacetate and acetyl-CoA. Now, this acetoacetate can be reduced to beta-hydroxybutyrate, or acetoacetate can be decarboxylated to acetone. So, three ketone bodies are seen, that is acetoacetic acid, beta-hydroxybutyric acid, and acetone. Acetone is liberated in the breath, and that is why in diabetic ketoacidotic patients there is a acetone smell in the breath. Now, the acetoacetic acid and the beta-hydroxybutyric acid are highly acidic in nature, and the blood pH may tend to become acidic. So, the blood buffers are acting to neutralize these acids. Now, the bicarbonate buffer is one of the most important buffers, and the sodium bicarbonate reacts with the acetoacetic acid so that sodium acetoacetate and carbonic acid is liberated. Now, so acetoacetic acid is a strong acid, and the carbonic acid is a weak acid. So in this manner, the pH is not considerably changed. But as the production of acetoacetic acid is increased more and more, the blood buffers are not able to maintain the pH. And there is excretion of large quantities of sodium acetoacetate, and so there is a hyponatremic condition in which the sodium levels are decreased below 120 milliequivalents per liter, and hence the electrolyte administration will have to be done in the diabetic ketoacidotic patients. Now, as the glucose is also excreted in the urine, the sodium salts are also excreted, and hence there is a large urinary output, and this leads to dehydration in the patient, and the patient will have to be administered a lot of fluids to prevent the dehydration. So this is one of the acute complications of type 1 diabetes mellitus, where there is a lot of ketone bodies produced, and large urine output, and the dehydration and electrolyte imbalance. Now, if we give insulin to such patients, then the whole process is reversed. Now the carbohydrate, the glucose is taken up by the various tissues, so hyperglycemia becomes better. That means the blood glucose level gets normalized, and the glycolysis is proceeding. More glucose is oxidized to pyruvic acid, and at the same time the lipolysis by the hormone sensitive lipase is prevented, because insulin is an anti-lipolytic hormone, whereas glucagon is a lipolytic hormone. Insulin is a lipogenic hormone, whereas glucagon is a lipolytic hormone. So the condition of the diabetic ketoacidosis improves, and the symptoms are rather corrected. Now, looking at the long-term complications of diabetes mellitus. Now, when we talk about the long-term complication of the diabetes mellitus, we are remembering about the glycosylated hemoglobin values. Now, glycosylated hemoglobin value is a very important indicator of how well the patient responds to the treatment. Now, glycosylated hemoglobin is formed when there is hyperglycemia. The hemoglobin gets glycosylated or glycated with the glucose. So the lifespan of the RBC is around 120 days, and so if we estimate the glycosylated hemoglobin today, then that will indicate what was the blood glucose level before 3 to 4 months. So how well the patient is responding to the treatment can be found out. Now, a glycosylated hemoglobin value of more than 6 is considered to be abnormal. So any patient having a glyco-HB value more than 6 has to be diagnosed as a diabetic patient. Now, so the glycosylated hemoglobin and or other the glycated proteins can be broken down, and it may actually cause a lot of damage to the tissues, like kidneys or eyes, nerves. All these tissues can be affected. Now, first important long-term complication is angiopathy. Now, angiopathy is the deposition of cholesterol in the walls of the arteries. Now, the cholesterol level in most of the diabetic patients is increased because, again, the cholesterol is synthesized from acetyl coenzyme A, and there is an increase in the amount of acetyl coenzyme A, which as I told you before can go for the synthesis of ketone bodies. At the same time, this acetyl-CoA also is the precursor for cholesterol synthesis. Now, up to the HMG-CoA stage the cholesterologenesis and the ketogenesis pathway, they are the same, but the HMG-CoA is acted upon by HMG-CoA reductase to produce mevalonate in the case of cholesterol synthetic pathway, and this mevalonate by a series of reactions is ultimately converted to cholesterol. So there is a hypercholesterolemia present in the diabetic patients. Now the lipoprotein metabolism is also deranged. That means there will be higher levels of LDL. The LDL could be more than 170 milligram percent. The total cholesterol may be more than 220 milligram percent, and the HDL, the high density lipoproteins, can be decreased. That means HDL decrease means the scavenging function by which the cholesterol is removed from the peripheral tissues is affected. HDL is, we know that HDL is a good lipoprotein which helps in the removal of cholesterol from the peripheral tissues and takes it to the liver for the excretion purpose. So the HDL is decreased whereas the LDL is increased. Now not only that, the LDL also can be glycosylated to produce glycosylated LDL, and also it can be oxidized to form oxidized LDL. Now the normal LDL is taken up by the LDL receptors located in the clathrin coated paves by a process of endosmosis. So this is a regulated process by which if the cholesterol level in the cells are increased, then the LDL receptors are down regulated. If the cholesterol level within the cells are less, then the LDL receptors can be up regulated. So as per the requirement of cholesterol within the cell, the LDL receptors can be up regulated or down regulated. So this is a regulated process which also takes care of the atherosclerotic process. But when in the diabetic patients, we know that this LDL is abnormal, either it may be glycosylated or it may be oxidized, and these modified LDL, more of that will be taken up by macrophages, and these macrophages become the form cells. Form cells are formed by accumulating cholesterol within it, and then it is cholesterol rich form cells. They migrate to the subintimal layer of the arteries, and there they proliferate. The smooth muscle cells are proliferated, collagen synthesis takes place, and all these form actually a plaque, that is an atherosclerotic plaque within the arterial wall, and more addition of cholesterol will make the plaque grow in size, and gradually the lumen of the arteries could be blocked, and thereby blocking the blood flow. So this is a block being created due to the atherosclerotic process. So this is one of the major complications of diabetes, long-term complications of diabetes mellitus. Now another that is known as angiopathy. Now there can be nephropathy in which there is due to the hyperglycemic state, there is glycosylation of the proteins of the basement membrane proteins of the kidney, and thereby the kidney functions are affected, and hence this results in the nephropathy, which can be identified by estimating the serum creatinine values. So nephropathy is another complication, and a third complication can be the retinopathy, where the glucose is increased in the lens, and within the lens glucose is reduced to sorbitol, and sorbitol cannot go out of the cell, out of the lens, and so it accumulates water due to its osmotic effect, and then the lens swells up, causing what is known as retinopathy. Then there is neuropathy also present. This is also because of increased level of sorbitol, so the neuropathy results. So these are the major complications of diabetes mellitus, the acute and the long-term complications. Now, when we talk of diabetes mellitus, then the forerunner of diabetes mellitus can be another syndrome known as metabolic syndrome. Now, metabolic syndrome is defined as a state in which the fasting glucose level is more than 100 milligram per deciliter, and some other criteria to decide metabolic syndrome is the visceral obesity, or the central body obesity, or the abdominal obesity, which can be identified by the waist to hip circumference ratio, or by the body mass index. And some other criteria to determine the metabolic syndrome is dyslipidemia, where the HDL levels are decreased than 40 milligram per deciliter, and the triglycerides, fasting triglycerides, are more than 170 milligram per deciliter. So these are some of the criteria to determine the metabolic syndrome. Now, it is found that those young persons who are suffering from metabolic syndrome can later on develop into diabetic patients if proper care is not taken. So this is a sort of lifestyle disease whereby there is availability of energy-rich foods, high energy-rich foods, and the easily available, and they are made highly palatable. So the person takes more calories than what is required. So our calorie intake should be balanced with the calorie requirement. If we take more calories, that will be deposited as fat, and obesity will be present. Now, this is added with the sedentary lifestyle of the present day generation. Now, it is found that there are more people taking or rather overeating than the people who are undernourished. Before about 50 years or so, before, the people were more undernourished than the overnourished. But now the condition has changed because of the affluence. The state of overnutrition is present, and this overnutrition, if concomitantly present with the sedentary habits, can create havoc in the body. So that's why the cases of diabetes mellitus and other lifestyle diseases are on the increase. So the main and also there should be a lot of diet adjustment will have to be done. The cholesterol has to be decreased. The triglycerides have to be decreased. The HDL cholesterol should be increased, and the LDL cholesterol should not be more than 170 milligram per deciliter. So how to make these changes? Now, these changes, the first thing is that to have proper exercise for about brisk walking for about 45 minutes every day. And another important aspect is the dietary changes. The diet should include more of polyunsaturated fats like linoleic acid, linolenic acid, and arachidonic acid. That means the oils containing the PUFA should be preferred. That means they are the vegetable oils like soybean oil, the sunflower oil. They all contain PUFA, and the fishes also contain PUFA and MUFA, that is monounsaturated fatty acid. So omega-3 fatty acids are good for reducing the cholesterol level. Omega-6 and omega-3 both should be present, but their ratio should be, that is the ratio of omega-6 to omega-3 should be around 4:1. So that is important. Taking either vegetable oils or the fish, food of fish is also quite healthy in that manner. And simple sugars like sucrose, etc. should be decreased as much as possible, and more complex polysaccharides or the fibrous diet should be preferred. And the less sweet fruits like apples or the guava or papayas can go a long way in decreasing the serious state of the diabetic patients. So, very sweet fruits should be avoided. Another important aspect as far as diet is concerned is that the non-vegetarian food should be restricted, especially when the cholesterol levels are very high, because the non-vegetarian foods, except fish, they contain more of saturated fatty acid, that is the stearic acid and palmitic acid, and which will actually increase the cholesterol level. Now the PUFA or the MUFA, that is polyunsaturated fatty acids and monounsaturated fatty acids, which are present on the second carbon of the phospholipid in high density lipoproteins. They are helpful because for the esterification of cholesterol, this PUFA or MUFA are added to the hydroxyl group of the cholesterol, and what we get is ester cholesterol. This ester cholesterol is taken to the liver for excretion along with the high density lipoprotein and also the LCAT, that is lecithin cholesterol acyl transferase. So the polyunsaturated fatty acid containing the foods or the oils are found to be helpful, and so should be taken in in moderate quantities. That is the soybean oil and this canola oil. All these are good for this, and so these are some of the precautions that should be taken, and by removing the fine sugars from the diet and taking more of fibrous diet. And these dry fruits are also helpful, that is the walnut and these other dry fruits are all good, and they also contain antioxidants, vitamin E, which are highly healthy for the individual. So by doing all these lifestyle changes, one can try to beat the metabolic syndrome, and its further conversion to the diabetes mellitus can be avoided.